All right. Hello, I'm Heidy Merius, and I am a student of the Stony Brook Bachelor's to DNP, which is a Doctorate in Nursing project program at Stony Brook University. I'm here to interview Dr. Rohan.
Pleasure.
So I'm just here to interview you from the GNSA, which is the Graduate Nursing Student Academy. Great minds in nursing, and it's just insights from nursing thought leaders. And immediately when I saw the email, I thought about you. So I'm here to interview you. Thank you for your time.
Well, I appreciate that you sent me this in advance, so I had a little chance to understand what this program is about, and I'm completely supportive of you interviewing me and learning about nurse leaders.
Thank you. So, what is your title, Dr. Rohan?
So my local title is an assistant professor of nursing in the School of Nursing at Stony Brook University. But within the School of Nursing, I have a designation of the Director of Pediatric Research. That's my position in the School of Nursing.
Please describe your nursing work and career. How did you get into your current position or research?
So I come to the School of Nursing with a very long career. I actually have 30 years of nursing under my belt. The camera's a little close, so you can see some of those grades. But I actually, I was a daughter of an immigrant, actually, who didn't really, my parents didn't really understand the whole college thing. And my grandparents, though, who also had immigrated, thought it would be they heard about college and they thought it was a great idea for me, and they actually funded me to go to college with the idea that I would only be a nurse or a teacher. So I picked nursing because it was one of the two, and I had a local state university where I could go to do that. And I graduated 4 years later with a bachelor's degree. They funded not just an associate's degree, they actually believed in a bachelor's degree. I graduated with a bachelor's degree, and that was in the 1980s. And at the time, there was a nursing shortage, such that many hospitals embraced nursing with big packages, both financial packages and housing packages. So I moved to Manhattan, where I worked for Cornell Medical Center, which is now known as one of the Presbyterian hospitals. I went from school right into the intensive care unit, which is unusual. A lot of people at the time could only go into med-surg right out of school. And that, interestingly enough, there was a career path to become a nurse practitioner embedded in that intensive care unit. At the time, there wasn't a requirement to have a master's degree or any degree to be a nurse practitioner. You basically needed to go to some certificate program. And the Cornell Medical College had a continuing education program for nurses, which would certify them as a neonatal nurse practitioners. I was in the newborn intensive care nursery. And after a year, people were selected for that program. It had to be a nurse who had a long potential to work in the unit, because there was a give back of about, I think it was 3 or 5 years. And also it had to be somebody who was technically good. They wanted people who were good at procedures. And I guess I fit the bill, so they sent me back full time to go to this 1.5 year program. And then I owed them 3 or 5 years after that. During that time, when I was serving out my time, which I loved that hospital, it was wonderful to work for them, very embrace their nurse practitioners, which at the time we sometimes called nurse practitioners and sometimes we called clinicians. We started to hear about the requirement for a master's degree for a nurse practitioner. As I said, this was in the heyday of nurses getting great packages to state institutions, so there was a deal at the time from the hospital that if you wanted to go back to school in your field, they would pay for all of it. So I was living in Manhattan. I applied to Columbia University. I was accepted into their master's program, and not knowing when the deal would end, I went full-time to their Master of Science program and received a master's degree as a clinical nurse specialist, because I already was certified in New York State as a nurse practitioner, licensed and certified by NCC and licensed by New York State. So at that point now, I was probably about 5 years out of school, out of my bachelor's degree, I was a nurse practitioner, I was a clinical nurse specialist, then had a master's degree. And I enjoyed working tremendously. Another thing that I did shortly thereafter is I had some good friends over here on Long Island, and one of them was Dr. Lori Escalea, who also was at the school. And they were toying with this idea of having a postmaster's certificate program, something that's very common now, but wasn't common then. Stony Brook University was one of the kind of forerunners in nursing education. It was the idea of having, somebody who had a master's degree become a nurse practitioner through a certificate program. And she asked me if I wouldn't be interested in being in the first cohort of pediatric nurse practitioner postmasters certificate students. And I said, oh, sure, that sounds like a good idea. At that point, I was starting to come to the end of my term for Cornell. I didn't need to continue there, although I loved working there. But, other things in my personal life had changed. I was married at that point, and I wanted to move out to the suburbs. So it actually sounded like a good idea to just come out here altogether. So I switched jobs, came out to Stony Brook Medical Center, where I worked as a neonatal nurse practitioner, went back to school as in that postmaster certificate program, and emerged as a pediatric nurse practitioner as well. Also became licensed and certified after that program. So that is kind of where I got my basic education. Then I sat still in my positions for probably about 10 or 12 years, which was a long time, and I wouldn't necessarily recommend that, but for me it was something that I did for my family. But throughout that time, I had this idea that I wanted to go back for a doctoral degree. So I targeted a certain time when I knew my kids would be a little bit older to enroll in a doctoral program. During those 12 years, however, I didn't sit still. Even though I was primarily a clinician, primarily working, I became a reviewer for a journal that was a clinical journal. They always embraced clinicians as reviewers, so I learned a lot from the editor of that journal. And Dr. Margaret Comerford Frieder, she has passed away since, but one of my greatest mentors. Remember, I didn't come from a family that had I didn't have a lot of local guidance on higher education, but she became my mentor. She's the editor of that journal, embraced me as a reviewer, even though I was a clinician, didn't have a lot of academic experience, trained me well or educated me well, and told me different things I could do on my career path. I got involved in quality improvement projects, which at the time weren't called quality improvement projects, they were called research, but there clearly was a type of research which was really aimed at quality improvement. I always, whenever there was an opportunity to have a researcher in the unit or somebody who collected data, even if it wasn't a funded position, I always embraced that. So I became involved in a couple of research projects. I began to review articles. I even actually was a co-author on a couple of articles, all as a clinician. And then when my opportunity came, I again applied to Columbia University because I had a history there and was accepted into their PhD program. So I went to that program when my kids were a little older, and then when I graduated from there, I took a faculty position. I moved to a part-time clinical practice. I had a couple of different jobs while I was probably in the last 5 years of my clinical career. I worked as a pediatric nurse practitioner in coordinating a large neurosurgical pediatric practice. I continued to do some critical care, but I also dabbled in some primary care jobs just to see how that was, since I was a pediatric nurse practitioner, mainly primary care. But then when I got this faculty position, I went part-time in my clinical work, and now because of my responsibilities to the university, I actually only have a per diem clinical position, so I'm primarily an academic now. I have a great number of research interests, and my primary research interest is in embracing biotechnology and informatics. The way I try to approach my projects are ones where we embed clinicians early on in development processes, nurse clinicians, so that projects that are aimed at developing new technology or developing informatics platforms are informed by people who have to use them. In the end, not just at the end, but in the development process. So my research really is embedded in that type of, in that concept. I also have some program interests. My program interests are certainly doctoral education, nursing, but also in bringing disadvantaged students into nursing, not just at the baccalaureate level, but at higher leadership levels. So I have right now a very large HRSA grant that supports disadvantaged students in their master's programs to develop primary care providers who are very inclined to go back to disadvantaged neighborhoods and provide culturally competent care. So that's very important to me from a program point of view. So when I write for research grants, it tends to be biotechnology. When I write for program grants, it tends to be for doctoral education, higher education, and for disadvantaged students, because I believe that is the key to serving our disadvantaged populations, to have people who understand the nuances of different cultures. So that's it, not in so much of a nutshell. I kind of went on and on, didn't I?
No, it's great. The progression is very important. I mean, I hear seizing opportunities, mentorship being very important. So thank you for sharing all of that information. So this is kind of like a multi-level question. How would you describe your leadership in the nursing and healthcare field in terms of these specific issues in nursing and healthcare does it address?
Okay, so I mentioned my interest in my programs my programming interest is in addressing the health disparities. So I think that my leadership there, I mean, the level of grants support that I have right now for that type of program is good. And so I think my grantsmanship is serving healthcare by embedding new providers with unique experiences and unique perspectives into our system. There is, for our disadvantaged students, we ask them where they would like to have their clinical placements, and we try to get them into areas where they feel that they can have the greatest impact, not just as a student, but knowing that often students are hired into their wherever they did their internships or their clinical rotations, they often are hired in those areas. So we really try to take students who we think could be very impactful in those regions and put them into those clinical settings. So part of my scholarship here is to also identify those settings. They're sometimes difficult to get clinical placements in because they are underserved, disadvantaged in terms of their funding, so they often don't have people who are reaching out looking for universities to have students. It's often difficult to have students in places where you're really working very hard to try to serve too many patients than, many more than you have, but we're really making an impact that way. So that's where my leadership in terms of, I guess, the health professions is, and in terms of healthcare, well, I'm certainly developing new technology, both as a mentor to students in this university, particularly in the engineering department, but I also have my own technologies that we're putting through licensing and commercialization processes. And those products, they are often using bactericidal light to prevent infections. Those products hopefully will make an impact on patient outcomes one day as well.
Okay, so everything that you basically described almost hit all of these questions that we spoke about. I want you to speak more specifically on the importance of having nurses involved in the earlier process when it comes to
Informatics and biotechnology. So I guess because I spent many years in intensive care unit where we use a lot of technology. We use technology even in home settings and in primary care settings and in low intensive care setting, low non-acute care settings. But in intensive care settings, we use a lot of technology, and invariably on a daily basis, I was faced with, as my peers were as well, technology or systems that didn't work well for end users. Items that were in the wrong place to be practical. And knowing now how much time, effort, years, and expense goes into building technology, only to find out that there's a light in the wrong place, after it's been manufactured in mass, or that it's too big or too heavy to work well with another piece of equipment that typically is found in a patient who's using that single piece of technology. That's really a bummer, because that expense could have been so easily avoided if a clinician early on would have been embraced in the healthcare, in the development process. Now, certainly nurses are not the obvious person to involve in the early engineering processes. They don't speak the language of engineers. They're not found in engineering departments. Most of them go to school in places where there aren't even engineering programs. So it really is a little bit of a challenge to get engineering programs to have an interest in bringing in somebody early in the process, who they have to acclimate to what it is they're doing, and even the language they use when they're speaking to one another. But we're starting to see, at least locally, how they love having somebody on the team who makes it real. A lot of engineers and informatics folks sometimes feel that without the connection to their end user, they're just doing stuff that isn't necessarily going to impact patients, and it's a little boring for them. We've heard that theme from quite a few different people. So once we get nurses who maybe are a little more developed in understanding what engineers and informaticians do, once we can train them to some basic level and then embed them into their processes, we're having great ideas percolate out of that. So that's what I'm doing in terms of my embedding clinicians early on in those processes.
That sounds really great. I mean, I'm just sitting here thinking like, whoa, like what does that mean for, kind of like nursing curriculum, and how is it that we can somehow bridge that gap towards maybe the language, or just early on ensuring that there is some type of communication between them?
Yeah, I am here with a very supportive dean for that concept. She is a dean in the School of Nursing that sits adjacent to a huge Center for Biotechnology and School of Engineering. So she's very appreciative of engineers, very articulate in that, and also really understands, this concept of having nurses early on in their development process. I think her idea is to, at some point, start this with either a certificate or master's level course or track. And we are entertaining those types of options. Right now, I'm a mentor to students in the School of Engineering, but we may actually develop a course that's listed in two schools. It would be the same course. The students would take the course together, but it would be listed in both the School of Engineering and in the School of Nursing. That's kind of a common thing to do for courses that there should be interprofessional collaboration, but it's never been done with nursing and engineering at this university. So that's next on our list.
That's great. How do these relate to the state and national policies? So you were speaking about basically culturally diversified healthcare professionals, and being able to effectively communicate with their clients or their patients, and also early involvement of nurses when it comes to biotechnology development. How does this address the state and national policies?
So in terms of policy, I'll speak to the biotechnology issue first. Certainly, reimbursement, this is one example. There's issues with reimbursing hospitals for care. And one of the big reimbursers of healthcare systems is Medicare. Medicare recently said that if patients endure certain types of complications while they're under your care, we're not going to reimburse you for a chunk of time or certain hospital days because you gave them something that they didn't have when they got there. Those things are usually infection-related. CORDY, which is catheter-associated urinary tract infection, CLABSI, which is central line-associated infections. So they're basically saying, if you're going to use medical devices in patients, you better be good about not having them infect patients because you can't make money when you've given the patient an infection. So that's huge for hospitals when they're losing money from Medicare. So a lot of the devices that we have to develop now are directed at preventing infection because not only is it bad for patients to have infections associated with morbidity, mortality, but now it's associated with non-reimbursement to hospitals. So that's kind of a policy issue that came up from the Centers of Medicaid, Medicaid that we're addressing through technology. So that's how, maybe the connection between policy and the technology piece. Then in terms of policy and getting a more diverse workforce into the community, I think it's no surprise that we do not do very well in terms of health outcomes relative to how much money we're spending on patients. Some of that relates to the fact that we have a lot of intensive care and we're not really understanding patients and providing them with the care that's culturally appropriate for them. We provide them with the care that's culturally appropriate to us. Intensive care, very, high-level procedural type of things. So I think that it's very important from a national perspective and in sync with many programs at the national level is to start to provide health care for people where they live, where it's important to them, relative to what their cultural needs are, what their personal interests are, and to get away from providing care that providers think is right. And I think this is a step in that direction.
Great. What will be better in nursing and healthcare because of your science and leadership?
Well, I hope that there'll be individuals, most importantly, there'll be, one by one, there'll be students who I've touched, just like Dr. Frieda touched my life. I hope that there'll be students along the way that I can be mentors to, who will go on, when I'm not practicing anymore, when I'm not a faculty member anymore, to do the work that faculty members do and that clinicians do. So that certainly I think is important. I would love if some of the technology that I'm working on that I've been funded to develop becomes significant in terms of improving patient outcomes. And I certainly would like to see a more diverse workforce that's helping patients to, not just patients, but communities and families to be able to be healthier within the context of their culture. And I would also like to see nurses from a programming standpoint, like to see nurses embedded in interprofessional programs, not just interprofessional with other health professions like dentistry, like medicine, but interprofessional with some of the hard sciences, with some of the applied sciences like informatics. That would be great.
Oh, that's
a lot of goals.
That's a lot broader than I initially I'm aware of, because I know about interprofessional collaboration between like an MD or a PA or public health, because we offer some of those courses here at Stony Brook, but you're broadening it to a totally different arena. So
sometimes it really is just a matter of sometimes it's just logistics. Health professions collaborate, certainly almost at any university where they have a lot of health professions, they collaborate easier because they're usually in the same building, in the same area of the university. So here, it's really easy. If it was just a matter of ease and somebody said, collaborate with anybody, the easiest thing for me to do is collaborate with, what is it here, the School of Health Technology Management, because they're right next door. Second easiest, medicine. Third easiest, something in this health sciences building that we're in. Little trickier is to collaborate with engineering. I have to kind of cross Nichols Road to get there. So we had, we laugh about some of these, or chemistry or informatics. It's like practically a mile walk for me to collaborate with informatics. But it makes good sense. So logistically, maybe we can't, we have to think about some of those things. Certainly, a lot of our online education tools that we've used in the School of Nursing are now being applied to those collaborations. It is not typical that engineering students are distance students. In fact, none of them are. And here we are in nursing and in healthcare, where we're certainly in nursing anyway, lots of our students. In this school, most of our students are distance students. That's unheard of in the Department of Chemistry. So we have a lot of tools that we can use that they're not familiar with to help with collaborations, because we know how to do a lot of that stuff just from our education. So I'm using a lot of that. The other good news, and I sell it all the time, is that Starbucks is really here in the Health Sciences Center, and I am a big fan of providing Starbucks for the meetings here. And let me tell you, it attracts providers across West Campus. Yes, so that has been very successful, and I'm not shy of mentioning that coffee and tea are big common ground areas for people when their language is very different. So
that's like a small incentive that has a large impact.
And it's really, I laugh about it just being coffee and tea. It's that you have to start with common ground when you talk to providers who aren't used to talk. Even our styles sometimes, we met one of the technology grants that I'm working with. I had to meet with a big group of different providers. It was a nurse, a microbiologist, a chemist, somebody from the Center for Biotechnology who was like a commercialization expert, and I came in my typical nursing, dress. That's what I wear to work. The chemist came in shorts. The engineer came in sneakers and jeans. We all were dressed completely different for our work day. And so the chemist looked around the room and said, I'm not being disrespectful for being in shorts, but I need to be able to rinse off my legs if something, spills. And just having that discussion about how we are different, but we do have some other common things is so important at the beginning of almost any meeting that I run. I try to bring in something that everyone likes, even if it's chocolate brownies or coffee or something that we have in common, because we all have to eat, we all have to drink. We talk a little bit about some of the things that make us different that are really obvious, like our dress or what our work week looked like or what our students were doing that week. And then we get on to other business. And we very, very commonly, we say all the time, if you hear a word that doesn't make sense, ask about it. Do not be too proud. To me, a lumen, for example, is the center of a catheter. It's the hole in the middle of a catheter. And for a while, we were talking about different applications, and the term lumen was being used, and I kept thinking of it as the center of a catheter, and for an engineer, it's a measure of light. And we were so confused, so we got really over that, and we said, can you say that a different way? commonly. Can you say that a different way? Can you explain what the meaning of that word is? And at some point, you can't have too much pride in that room.
Right.
You really have to understand how complicated. You really learn that you have to speak in ways that other people can understand you to really know what you're talking about.
It sounds like there's a real science to
I think
having
there is. We're working on it.
I'm
We're
listening.
working on it.
Oh, wow.
Yeah, we're working on it. It's it's sometimes harder to explain what you know in simple terms than it is to explain it to somebody who knows what you know.
Right.